Good day, everyone. Thanks so much for joining us for today's knowledge sharing session. I'm happy to be joined today by Jason Potts and Dan Borgasano as we have a conversation about best practices for combating drug diversion. There's some key topics that we're going to hone in on some requirements, key requirements as we think about regulators, some program gaps and possible workflows, compilation of data, some key value and common acts that we're seeing within this space and more. So really excited about today's program. I think it's always great to start out with, who do we have on the phone? Who do we have on the line today? For those that I haven't met or you're not aware of who I am, Michelle Drake with Imprivata. My background has been in the healthcare space for the last 25 years. I've had the pleasure of serving as a privacy officer in a large physician-owned practice here in Texas. I've also served in the United States Air Force in the Medical Corps as a non-commissioned officer. I was able to spend some time working with some health plans in the hospital and physician practices, as well as some time working directly with, from a consultancy perspective, working directly with privacy, compliance, security, cybersecurity professionals as they build and mature their monitoring programs within their healthcare delivery settings. So that's a little bit about me. I always want to learn more about my guests, as I'm sure you do as well, in their own words. So Dan, Jason, I'm going to be turning the table to you in just a moment here. But Jason, I'm going to start with you. Would you kindly share your professional journey that brings you from your studies at Colorado State University, Pacific University, to your current role today at Imprivata as our clinical workflow specialist?
Yeah, thanks, Michelle. Happy to be here. Happy to see everyone joining. As Michelle said, I've been all over now, but the long and short of it is I started out in pharmacy and I went to pharmacy school at Pacific University. I did 2 years of residency just outside of Boston, specializing in critical care. And then I moved to Montana. I love crossing back and forth across the country, it would seem. And started my work as a clinical pharmacist in a hospital. I worked primarily in the ICU and emergency department, and kind of kept doing that for the last 10 years prior to joining here at Imprivata. And how I got interested in diversion and what pulled me into this scene is the unfortunate truth that I had a friend, a colleague, who ended up getting caught in drug use disorder. Great intentions, never wanted to go down this road, had a surgery, got pain that was out of control, and spiraled and didn't get caught for longer than it should have. And once he was caught, was so happy that somebody had finally been able to stop him because it had been spiraling too quickly. And so that really hit home quickly and got me looking into what it is we can do to try and help prevent that, because it not only harms the person who's diverting, but all the other patients involved. So that's a little bit about me and why I'm here today. Turn it over to you, Dan.
Great, thanks, Jason, and thanks, Michelle. So, hi everyone. My name is Dan Borgasano. I'm Vice President of Solutions Marketing at Imprivata, and my role is to really understand the challenges that our clients face, and then offer up how Imprivata might be able to help them solve them. Before I was at Imprivata, I began my career working for a public relations agency where I spent a lot of my time primarily working with cybersecurity startups as well as pharma companies, which then led me to Imprivata, where I've been with the company for more than 10 years, and much of that time has been focused on EPCS, or electronic prescriptions for controlled substances, which we'll talk about throughout this session. So I've become very familiar with DEA rules around EPCS, the various state and federal legislation, and best practices for implementing EPCS in a way that will address drug diversion while giving your providers kind of that seamless experience. So I've really seen the positive impact that initiatives like EPCS can have on drug diversion. And I look forward to kind of the continued evolution of EPCS and other initiatives to hopefully, one day really eliminate drug diversion altogether.
Thank you, Jason. Thank you, Dan. It's always helpful to learn a little bit more about our guests, and really appreciate you sharing your stories. So clearly we've got the right folks on the call today as we continue our conversations. Ali, I'm wondering if you could take a moment and put up the first polling question. it's always nice to know from our audience's perspective. Let's learn a little bit about our audience. And would you kindly take a moment and just let us know how you'd rate your current drug diversion inpatient and outpatient monitoring program's maturity? Is it, we've got it all covered? Our program includes a comprehensive, holistic monitoring program that detects both inpatient and outpatient events, reporting, and dedicated resources. Is that we have a monitoring program receiving meaningful results, but maybe some to-do items still working in the maturing phase of things? Or do we have a bit to go? We have a long way to go, a little bit of a to-do list to get to that mature level? Or what is a drug diversion program? And it looks like we've got most of the folks here have logged in to participate. So thanks so much, everyone, for taking a moment. It looks like it's a little bit of a tie between we have the second and third option. So I wouldn't say everybody has it all covered, but most people fall into we do have a program. We've identified some ways in which we need to mature, and or we have a long way to go to get to maturing. So we don't have any of the outliers on the top or the bottom. Jason, Dan, any surprises there from the audience?
No, I honestly, I'm relieved a bit to see that nobody answered the top one. Anybody who thinks they have it all covered is probably just burying their head in the sand at this point, because the statistics out there are showing that, we don't have it covered. It's still a growing problem. And even more interestingly, the statistics during COVID show that the budgets and support for these monitoring measures were reduced across the board pretty much. So even if you had a once great program, it may not be as good as it once was. So I think we all have room to grow in the industry as a whole.
Yeah, I agree. And, I sort of liken, drug diversion and combating drug diversion to cybersecurity, right? It's always going to be evolving. It's always going to be changing in the cybersecurity world. Threats are always evolving. Bad actors are always trying to find new ways into your systems and to access data. And unfortunately, it's the same with drug diversion, right? As we put up our defenses and our programs to combat drug diversion, the diverters are going to look for new ways to get around those. So, I think it's great that everyone's sort of acknowledging that while they may have certain steps and pieces in place, it's definitely an ongoing, evolving process. And it's great to see so many folks on the call today, because it tells me it's something they really want to continue to invest in and continue to address.
Excellent points, Jason and Dan. Thank you. I like the, comparing and contrasting it to a cybersecurity program. You're right. The ever-changing evolution, ever-changing landscape, and we just need to stay vigilant as a collective group of professionals. So let's no test at the end, I promise, audience, but let's just throw a definition out there. So as we think about how drug diversion is defined, and I'm pulling this from Health and Human Services, or HHS, where we look at drug diversion and describe it as the illegal distribution or abuse of prescription drugs, or their use for purposes not intended by the prescriber, whether it be prescription drug diversion occurring at any time as the prescription drugs are distributed from the manufacturer to the wholesale distribution to the pharmacies or to the patient. So just kind of thinking about, this is a very big, very large area that we need to look at in terms of drug diversion and how, goes from start to finish as we think about the supply chain, if you will. So Jason, I'm going to turn to you a bit here as we reflect on our American television series such as Nurse Jackie, which I have to admit, I definitely watched that series from start to finish. It followed Jackie Payton. Eddie Falco is playing the role as the drug addicted ER nurse that was at the fictional All Saints hospitals. Or you're listening to the evening news and you hear about a current story about what's going on with the recent opioid epidemic situation. Where are we today with drug diversion?
Yeah, I think that's a great question. And I'd say that we're definitely growing and changing. But as with any problem, the people who are committing these crimes are also growing and changing. So diversion was classically thought of as an outpatient problem. And we're going to spend a good amount of time talking and think about some of the things that we've done to try and solve some of the issues in that realm. More recently, we've started to recognize that, healthcare workers, surprise, they're humans also. And wherever there are humans and controlled substances, there's potential and probably diversion going on. So focusing on fully on the outpatient probably isn't going to be enough. We need to be able to be looking at a controlled substance wherever it's being used, because of just really it's about the way that these drugs work, what they do, what they feelings they give people, and then the addiction that comes secondary to it, or dependence that comes secondary to it. And then add in a little bit more recent developments. The COVID crisis, I think, is a big component here too. And in my mind, it added what I think of three major developments in the COVID crisis. The first one is increased levels of anxiety and stress. That's well documented in psychiatric journals and all the different places. Everyone pretty much on the whole experienced higher levels of anxiety and stress. This drives the rate of abuse of drug use disorder. And when there's more drug use disorder, there's more diversion. The second one is the staffing burden in our hospitals, clinics, outpatient pharmacies went through the roof. Shortages in all of those workers and the inability of those workers to be able to provide enough workers to meet those needs. And this is kind of multifaceted. And one of the big ones, though, is that it increased the amount of per diem or traveling workers, which is a recognized group of people that have an increased risk of committing or being a part of diversion activity. And also, secondarily, they're much harder for software or people to track. You can think of, I have a trend, I'm able to trend people over years of their employment, then it might be a little bit easier to see when things are going awry. But when we're talking about somebody who comes and leaves within a matter of weeks, that's really hard to detect and combat. And then the last piece I spoke about briefly before is that the decreased resources to combat the issue. Healthcare has been crunched. Hospitals have been crunched. You've seen the margins sliding and the need to cut costs. And one of those things that can be easy to cut is something that's considered, extra monitoring, paying more attention. The staff that often do this are pharmacy technicians. There's compliance, there's pharmacists. Okay, they had patients to take care of. They had drugs to get to the floor. And so you can imagine some of these things got moved down the priority list. So those are kind of, I think, where we are. I think the last good statistics I saw were in 2021, and they showed a continued increasing incidence of drug diversion that was being identified. And then the other good data that we can have is the incidence of drug overdoses. You assume they're getting the drugs from somewhere. It could be increased shipping into the United States, but it could also be increased diversion. And we know that those numbers are also increasing. And so it leads us to believe that there's probably a worsening and increasing problem around this.
Thanks, Jason. Let's shift gears a bit and talk about outpatient or ambulatory diversion first, and ways in which healthcare delivery organizations are addressing drug diversion and how they've been effective. And Dan, let me turn to you, and if you could comment in that area for us.
Sure. So, there have been a variety of different initiatives implemented throughout the years that really are designed to address all facets of drug diversion. Over the past decade or so, we've seen two particular strategies gain significant momentum. So these are PDMPs, or prescription drug monitoring programs, and then EPCS, which I mentioned earlier, that's electronic prescriptions for controlled substance. So many folks on this phone, if they're on this call, if they're in compliance or pharmacy departments, they're likely familiar with these two initiatives. But for those who maybe not, PDMPs, prescription drug monitoring programs, are electronic databases that track controlled substance prescription in any given state. They're state run. And they're really designed to give healthcare providers information about prescribing and patient behaviors that may indicate doctor shopping or other drug diversion techniques. Now, EPCS is the process of electronically sending a prescription to a retail pharmacy instead of using a paper, a printout, or a prescription pad. And so the idea is that you'd reduce the risk associated with copying the prescription paper or falsifying it in some way, or diverting it altogether, right? Instead, EPCS gives you a more secure and fully auditable record of that medication from the initial prescription through to the dispensing. Now, these two approaches, PDMPs and EPCS, have been available for some time, but really they've started gaining momentum over the last, say, 5 to 7 years, thanks to state and federal legislation. So New York was the first state to mandate the use of PDMP and EPCS with its groundbreaking I-Stop law that I believe was passed around the 2015 timeframe. And so this law, like I said, is the first of its kind. And it was a requirement that said providers needed to check the state's PDMP before prescribing controlled substances. And it also required all controlled substances to be prescribed electronically. So that was sort of the catalyst for other states to follow suit. And since then, there have been dozens and dozens of other states that have enacted similar legislation, both on the EPCS and PDMP side. In fact, I think today, more than 30 states have an EPCS requirement in some form or another. Most of them have gone into effect. Others that were passed in the last year or two are going to be taking effect over the next couple of years. Now, from a federal perspective, in 2019, the Support Act introduced a number of initiatives designed to address the opioid epidemic, one of which was an EPCS requirement for all controlled substances prescribed through Medicare Part D. So all of these were designed to create a more secure environment for prescribing controlled substances and avoiding diversion, doctor shopping, and other things that contribute to the opioid epidemic. So you asked about effectiveness. So as far as how these programs have helped, the ONC recently released a brief, it was earlier this year, that was looking at data from 2021, so a couple of years ago, but it's the most recent data that they have. It found that more than 70% of providers who prescribe controlled substances do use EPCS technology. So they're using, generally speaking, the technology that's available to them to provide a more secure environment. Even more than that, nearly 80% said that they did check their state's PDMP before prescribing a controlled substance to a patient for the first time. And this was largely driven due to the increased integration of the PDMP into the EHR or prescribing application that they're using, which makes it much easier to work with. When these PDMPs were first released, the provider had to navigate to a separate website, log in a different way, find the patient, and it really sort of convoluted the workflow and made it a little bit more difficult. But now that they're integrated right into the EHR, makes it a little bit more seamless. The frequency also with which providers are using EPCS, so they're using it more times, like I said, more than 70 who prescribe a controlled substance are using EPCS, but they're also using it more regularly. Now, this is great progress, but the goal, of course, is to achieve much higher adoption rates. You might say with all these state laws and with this federal support act for Medicare Part D pending, why aren't we closer to 100%? Well, there's a number of different reasons, and Jason will talk about those in just a minute, but 25% of providers said that they rarely or never use EPCS, which is much higher than it should be, given given the effectiveness of EPCS and given those state laws. I think, as Jason, maybe you can attest to, like, a lot of this has to do with usability challenges from the provider perspective.
Yeah, I'd be happy to talk a bit about that. I think it's a balancing act, I think, is what I'd say primarily. There's two pieces here. Obviously, you want the drugs to be used and only used for the right purpose, but you also don't want to stand in the way of the patients getting the care they need. And that's kind of where this balance comes in. You can imagine if I'm a rural practicing physician with a single office who travels around to see patients in a rural area, completing an EPCS order might be quite difficult, especially if you don't have an EHR that's formally set up. Checking a PDMP is going to be burdensome in that scenario, but you still want to be able to provide the best care. So it's kind of difficult to know how to get 100% and make that available. And there has been funding programs, there's been ways that the government has tried to improve this adoption outside of just regulation, because there's always hopefully a carrot and a stick. But from our perspective, there's a couple other barriers. So I always think back, my dad was a ER physician. He worked in an ER on I-90, which is a major artery crossing the United States. And he would have patients come in all the time with real problems, broken arms, broken backs, broken everythings. And they'd want pain medication, appropriately want pain medication. But as the opioid crisis continued to grow, more and more we were finding there was a population of people who were moving through. They were literally traveling the interstate, stopping at every hospital along the way with their truly broken arm and getting opioids for that to treat it. And so one of the major limitations of these PDMPs, which are doing a great job, is that for the most part right now they're statewide. Some of them are expanding, so you can access maybe up to 10 states in one PDMP search. But you can imagine if I'm traveling across the United States, stopping at every hospital, there's a good chance I can get drugs in many different hospitals and they won't show up when that doctor goes to fill that prescription. And this unfortunately leads to this distrust status, to the point where the physician doesn't feel they can trust the truth of what the patient is telling them if they want opioids, which is not a place we want to be. Another one is accurate personal identification. Who knows, if you're coming in, you have maybe an insurance card, maybe you're paying cash. You can provide me with any identification you want. As a doctor or a provider, I'm going to provide you the care you need. And so maybe they give you a false identification. PDMP is not going to be successful in detecting that person then, because you don't know who they really are. And the same thing can happen at the pharmacy when they go to fill it. But I think the key pieces here are, you have to do the best you can and take care of the patient in front of you. So our job is to make that data as easy for those clinicians to access as possible, to make the EPCS as easy to do, make it easier than writing a prescription on a paper and pen, with paper and pen. And we've come a long way, but most of the focus has been on those big groups, those EHRs. If you're using one of the big ones, the process is a lot smoother. If you may be using a much smaller homegrown system, it's going to be more difficult for you to do that, and it's going to make it more difficult to do the right thing, I guess is what I'll say.
So interesting points that you bring up. Dan, I'm curious from your perspective, why do you see these challenges? Why the presence of these challenges?
Yeah, so a lot of it, as Jason mentioned, has to do with that balancing act. And so, specific to EPCS, while the language for each of the various state laws differs, from state to state, some talk about all controlled substances, some focus on only Schedule II controlled substances, others actually talk about dispensing and only being able to dispense a controlled substance if it was an electronic prescription. So they all vary a little bit, but fundamentally they all require delivery organizations to adhere to the DEA requirements for EPCS. So these requirements go all the way back to 2011. The DEA issued its interim final rule, or IFR, which really paved the way for EPCS. And a lot of the requirements, they're very unique and specific. And so there is a balancing act of getting those right, getting the security piece right, the compliance piece right, with taking into the practicalities of the workflow and doing what's best for the providers and patients ultimately. The DEA's goal is to ensure non-repudiation, as they say. And really what they mean is they want to make sure that in an electronic prescribing environment, all prescriptions can be tracked back to the source. So in the event of a diversion event, you can be sure unequivocally that a prescription was provided to a patient, sent to a specific pharmacy from this provider at this time with all these relevant details. Unlike with paper, which can be easily forged, etc., an electronic trail must be present so that you can conduct your investigation. So as a result of that goal, the DEA requirements are very unique and complex and often open to interpretation in many areas. So I think one common requirement that a lot of folks know is that providers are required to use two-factor authentication at the time of prescribing. Before they can send an order through to the pharmacy, the provider is asked to provide two forms of authentication. Typically this goes like something they know, a password, followed by something they are, a biometric, or something they have, like a hard token, or maybe their phone, right? But depending on the methods used, it can be cumbersome and inefficient to use two-factor authentication for every single prescription, especially if you're in a busy ER or an orthopedic clinic where you may be prescribing a higher volume of controlled substances. On top of that, this two-factor requirement is just one of the many other requirements that the DEA has. Again, to establish this secure chain of trust that we like to talk about, you need to make sure that the identity of every provider is confirmed. Jason talked about, needing to be sure of the identity of patients and the tough position that puts providers in. Well, the same is true on the provider side, right? We want to make sure that a provider is who they say they are and that they're authorized to prescribe controlled substances. So the DEA requires a very specific identity proofing process through which the provider needs to prove their identity. They are who they say they are. And that has to take place when enabling EPCS. So even if a provider is already credentialed at your organization, you have to go through that again before you can give them EPCS. It can be done in multiple different ways. So it's really important to understand the rules and determine what's best for your organization. There's also an EPCS approval process that needs to be separate from the identity proofing. And all of the components of EPCS, from identity proofing to issuing credentials to signing the order to granting permissions for EPCS within the EHR, all has to be audited, and there needs to be records that need to be easily reported. In the case of an incident, the DEA needs to see those. Oftentimes they need to be produced within 24 hours when an incident is noticed. So given all of this complexity, it sometimes can create a challenge for organizations to fully implement an EPCS solution that is something that will drive adoption for providers. And hence we see that lag a little bit in adoption where you might expect they would be. And Jason sort of referred to maybe rural clinics, but this is also particularly relevant for, say, smaller practices or clinics where budget and resources to administer a proper process may be potentially limited. So what I would say is that as a lot of these state laws start to take effect and as that Medicare Part D requirement goes into effect, I'd really recommend going back and looking at your EPCS process from two perspectives. Number one, do we meet the compliance requirements from the DEA start to finish? Can we really be sure of that? And could we prove it in the event of an audit or an investigation? And number two, have we given our providers the best possible workflow in all scenarios? If you've only got one method of authentication, for example, that may work in a lot of cases, but it may not for other providers. So, again, given all those complexities, I would say, really look at your process and make sure you're meeting all the requirements again with a workflow that your providers will adopt.
Thanks, Dan. Really great way to outline those challenges. We did have a question from the audience, and it had to do with some suggestions on or related to their leadership. And I think we had mentioned a bit about leaders with their head in the sand. And do we have some suggestions on perhaps how to address that or to kind of get in front of those situations?
Yeah, I think there's always as always, there's usually a multifaceted approach that's going to be needed. The easiest and most straightforward way, I think, is to note the requirements. A little bit of a scare tactic can even be used at times, which doesn't sound great. But if you go to the DEA, they tell you about drug diversion cases and those that have been settled, and the fines that have been associated with those institutions that when they get them. And it's easy to say, well, that's not going to be us until it's you. But if you can really think about those in advance or bring those to those people's attention in advance, then that can be great. The other thing is I'd be remiss in not talking about the ASHP guidelines for drug diversion. This primarily focuses on inpatient, but it clearly speaks to what's considered best practice for inpatient drug diversion. So if you can bring that forward, if their direct leadership isn't listening, Then hopefully there's a practice council or something similar that you could go to have those discussions about this is considered best practice in the industry. And if we aren't doing this, it is certain that we will be held accountable if and when a diversion event happens from the DEA. And then on the soft side of things for me, but equally as important, the people who are doing these diversions in the hospital are our friends, our colleagues. It's our diligence, it's our duty to watch for this and help them get out of it as quickly as possible.
Well said, Jason. Thank you. So let's talk about a little bit about what can be done to increase our adoption of EPCS to achieve the desired objectives. Jason, from your clinician's perspective, could you provide some perspective or some best practices for improving PDMP and/or EPCS, or if you want to answer for both?
Sure. Yeah, I think we've touched on a couple of these pieces, but I'll reiterate them. I think the most important thing, honestly, is happening already. So with which is, and in the end, unfortunately, government regulation, with the government coming forward and now with Medicare or Medicaid coming forward requiring EPCS in these scenarios, it's going to drive adoption. If you want to get the funding that you are due for taking care of these patients, you need to follow these regulations. And so I think that's was the way to improve this adoption across the country. And then as far as getting people more engaged and making them more usable, it's being as least disruptive as possible to the care of the patient. There's a lot of literature coming out on cognitive dissonance and having to take your attention away from taking care of patients and how that negatively impacts that patient. So if we can make EPCS second nature easier, like I said, than writing a prescription, if we can make the use of a PDMP straightforward and readily available when it's needed, that's really going to drive the use and adoption of it. And for me, that one obvious one focusing on PDMP would be a national PDMP. Like I said before, these independent states where you kind of have to look, but also recognizing the number of issues that comes with. Again, we go back to that patient identification. If you make it national, how are you going to uniquely identify the appropriate patients and also make sure that people who don't need the information don't go and get it? Flipping over to that compliance side, that is patient private information. So the HIPAA issues with that would also be very large. If you have access to everybody in the nation's controlled substance ordering history. So I think there's pieces there, but those would be a couple of recommendations. Dan, do you have anything to add on to those?
Yeah, for sure. I think to kind of push the EPCS adoption rates higher, you really need to remove the barriers, right, or even the perceived barriers, right? Starting with that workflow. If we make it easy as possible, it should drive adoption. I alluded to this a little bit, but if, as I said, if you're only giving one option for sort of that two-factor authentication, you're likely not giving your providers the best possible experience. So, for example, if you're using a password plus a phone-based token to complete that, what happens if a provider doesn't have their phone with them? Do they revert back to paper? If so, that undermines the importance of EPCS to addressing drug diversion. Or do they simply wait till they have their phone with them to complete that order? If that's the case, then patient safety and satisfaction are potentially compromised because that patient will have to wait longer for their medication. So ideally, you'd offer multiple options in that scenario. You also want to give providers flexibility to use the best possible combination that meets their workflow. So, for example, we hear in a busy ER, phones may not be easily accessible. So something like a fingerprint biometric may make sense in that scenario. You want to make it second nature, as Jason kind of mentioned, just seamlessly part of the workflow without thinking about it. And importantly, we're just coming out of this initial phase of EPCS where it's being implemented, again, driven by all this regulation. But now we're going to move into the phase of optimization and really scaling it out. And so when you think about that, it's how do we enable electronic prescribing, particularly for controlled substances, from remote locations, so that we can make sure providers can treat their patients and give them what they need as quickly as possible. So for example, if a provider wants to use their mobile device, if they're outside of the office, if they're on the go and they need to send a prescription through, we want to be enabling EPCS on a mobile device. You know, However, like given the breadth of the DEA requirements for EPCS as well as the uniqueness of the workflow, the traditional multi-factor authentications that we have for all the other workflows in our organizations are typically not sufficient. And trying to use them will likely limit adoption. So it's really important to connect with clinical leadership to understand all facets of the EPCS workflow, to again get the most value out of that when it comes to drug diversion. Because Jason mentioned a national PDMP. Well, you know, ideally in the future we also have integration between the EPCS workflow and PDMP as well, so that it's as real time as possible in terms of that prescribing data. One thing that I've always sort of sympathized is that providers are put in this very difficult and compromising position of having to make a decision in the moment of whether or not to provide medication to their patients, while also looking at this other data that may or may not indicate kind of a red flag, right? And that's not the position we want to put our providers in. So giving them as much data in real time as possible will ideally make better decisions, and we can continue to treat patients while also addressing drug diversion.
Thanks, gentlemen. Ellie, could you launch the next polling question? I think this might be an interesting time to ask the audience for some information on their programs, as well as we're going to talk about your confidence. How confident are you in your full end-to-end compliance with regulatory requirements for electronic prescriptions for controlled substances? Are you 100% confident you've got this with a centralized solution? Are you fairly confident? You've got defined processes in place, meeting all the key requirements, but you're using different products and systems, so it might take a little bit more legwork. Somewhat confident using that two-factor authentication, but not sure that your identity proofing and all other elements are fully meeting regulatory requirements. Or what the heck is EPCS? And it looks like our audience is answering that question. Thanks everyone for participating. We do have quite a few that are 100% confident. That's excellent. About 33% are fairly confident in their program, and 58% are landing at somewhat confident. Nobody is questioning what EPCS is, so that's excellent. Way to go, audience. Dan, Jason, comments?
Yeah, I mean, I'd say from my perspective, what really happened was once the states started enacting these laws, it really set a lot of organizations kind of scrambling to meet the requirements, right? And because they're so unique and so complex and so open to interpretation, a lot of folks, maybe implemented sort of the basics of what they needed to comply with some of the components, right? And that's okay. That's certainly understandable, right? And so what we saw was that two-factor authentication, most obvious piece. We integrate it with our EHR, and okay, there we go. But again, there's a lot more to the requirements, and I think, as I said before, this clearly indicates. I would suggest going back and reevaluating your process, start to finish. And Imprivata can certainly help you do that, given our experience. But really just to make sure that you've got all the components of compliance buttoned up. But bigger than that you really addressed any gaps that would potentially lead to drug diversion. I mean, after all, the reason we're doing this is to create a safer environment for both your providers and patients. And so if you do have gaps in compliance, it means there might be ways for people to circumvent the system and divert.
Thanks, Dan. So let's turn the corner a little bit, and thank you, audience, for the information, kind of where things stand today with your outpatient. And we've been talking a little bit about outpatient prescribing as it relates to electronic prescriptions for controlled substances, as well as a prescription drug monitoring program. What about procedures, and what's typically in place to prevent diversion on the inpatient setting? And Jason, could I turn to you for some comments as it relates to our inpatient cabinets, if you will, and witnessing?
Definitely. The inpatient and outpatient worlds are obviously very related, but extremely different when it comes into drug diversion. First, I'd like to just hit real quick on why it's so important that we monitor and hit for this, because I think some of it is very straightforward, but others it's not. So what's different about outpatient and inpatient? In inpatient, the access is even more ready. There are controlled substances on, I would say, almost every floor in every hospital in one version or another, and they're being used on a regular basis. With ready access, obviously, bigger problem. As I mentioned before, all healthcare workers are human, at least that we're aware of. I think my friends would say I'm a little weird, but probably not quite alien yet. So I still am human and could have a downfall. That comfortability and frequent use leads to a really comfortable situation. You see these drugs being used in the appropriate situation all the time, and so you become comfortable in thinking that they're safe, which just lowers that barrier for some people for that first use. And then the big piece here is downstream effects. Yes, when a person diverts, it's illegal, and that person could easily be harmed. But what else could happen to the system? So the first piece that comes to mind is, so they're diverting opioids, likely from going to a patient who needs them. So that patient is no longer receiving appropriate pain medication. This could be even as far as in a procedure. They could be undergoing surgery and not receiving the pain medication they need. And I think anybody who steps back and thinks about that immediately gets the little heebie-jeebies. I just got it again, just thinking about it and how that experience could be. Also, a lot of those healthcare workers are then taking care of patients in life-saving situations while altered. So are they actually able to provide the appropriate care that those patients need? Probably not in many scenarios. So that's another risk. There's also a lot of adulteration of drug, which, not to get into the specifics on what that means, but essentially a user might dilute the drug, pull some out of the vial, inject it, and put some water back into the vial, so that it doesn't appear to have ever been accessed before. And in this scenario, there's huge infection risks. So if someone's been doing this, and then those drugs are then drawn out of that vial and given to a patient, that patient is exposed to such a huge amount of infection risk and could be getting bloodstream infections, surgical infections, which is massive. And lastly, and maybe a little bit, I could say leastly, there's going to be a financial impact when this all comes around. When the diversion is detected and the policies are looked into, there's going to be a financial fine likely levied and reputational damage, as every single patient who is affected will have to be notified or potentially affected. So huge reputational damage. Sorry, a little bit of an aside, but I wanted to set the table. So why do we really need to keep caring? The other major differences here is we have what we consider a more controlled environment. So EPCS, electronically prescribing, that's the standard now in most hospitals. So we don't have to force the communication to be electronic. It's already happening. You're putting the order in your EHR. We know who entered the order. You're signing in securely. So we have that component. And we also have a good history of what that patient's received. We have a medication administration record at most hospitals in the United States. So that's kind of that PDMP component. So we're monitoring for kind of those two pieces by default when having an EHR. So we need to kind of take it to the next level and monitor for trends in patients, trends in accesses, how people are getting in their drugs, and are they doing all the right steps. So the first step is being regulatory compliant. And then, sorry, I should probably, hopefully a lot of our attendees are hospital employees, but it's always hard to know. So a little bit back up again. So most of the time the drugs come from the drug manufacturer into the pharmacy department. They go into what's called a vault, which is basically an electronic storage container. Then they're dispensed from there, and every transaction from there is audited. And then they're delivered to either directly to the patient or into an automated dispensing cabinet. For that, then the nurse comes, takes the drug out, and administers it to the patient. And so we need to monitor all of those steps to make sure they're being done appropriately and that the trends are appropriate. So I think that's a good start for the typical procedures that are in place at most hospitals today that are helping monitor for drug diversion.
Thanks, Jason, for walking us through those procedures and giving us some background to kind of really set the table, as you mentioned. And these procedures, these methods, are we finding them to be as effective as they should be?
I think everything can be more effective, but I think the realization that we come to is even if we did all of that perfectly, so we said every drug that entered our walls was either given or wasted appropriately 100% of the time, we would still not catch all of the diversion because it's possible to have perfect documentation and still divert drugs. And so even if we did all of that right, we could still have a good amount of diversion happening from the administration of partial doses, the dilution of the vials, as I mentioned previously, replacement of drugs within those ADCs. There's so many ways for drugs to go. So we need to do more. We need to go beyond just being compliant with making sure 100% of the drugs are given or wasted, and we need to take it to the next level. And I think the big pieces here, I try to put three of them, limit myself. The first one is education. Staff need to be aware of diversion and how it causes problems in hospitals, as well as the signs and symptoms that are common in healthcare workers who are taking part in diversion. Statistically speaking, if you go and look at diversion incidents that have been reported and how they were caught, the largest number still today is being reported by other healthcare workers or patients as potentially suspicious. We know each other, we work very closely together. If we're seeing it, again, it's not only for them, for the healthcare worker themselves, but all of the patients that they're taking care of, that it really needs to be taken seriously. And you need to have a reporting structure so that can be done as easily as possible and without damaging those relationships. Second piece is a data analysis or trending. It needs to go above and beyond just making sure everything's reconciled. You need to look at, is there a particular user who is pulling 300% more fentanyl than any other user? Is there a user who's wasting 300% more than any other user? Are they accessing the cabinets and then canceling the transactions? There's all these pieces of trending data that can lead you to help you detect these diversion incidents. And then the last piece is using a piece of software that includes either artificial intelligence, machine learning, or preferably both. The number of data points that you have to go through to get and find these diversion is astronomical. And historically speaking, was done on a random audit basis. So, we audit 2% of all transactions and hope we find the ones that are bad. Well, AI and machine learning can audit all of those transactions and help identify those truly meaningful or potentially risky behaviors that are occurring so that you can investigate those without using additional manpower, which we all know is in short order.
Yeah, and Jason, I think what I would add there are a couple, just double down on that sort of training, right? I mean, this is really, monitoring in whatever way that whatever form that takes for drug diversion for our internal staff is really something we're trying to do for our coworkers, right? It's all about their safety and patient safety as well. So it's all about trusting but verifying, right? And getting folks on board and really establishing that kind of culture of trust and best practices, and giving people that opportunity to kind of come forward if they see something. I think that's a really important point that you made earlier. The other thing from a technology perspective, I would say is, you talked about things like dispensing and witnessing and wasting medications and all of these touch points and opportunities to potentially divert. And we know that the EHR and other applications have ways of tracking and auditing these, but there are ways sort of around that, right, to fool the system, and you sort of alluded to that. So I might also reevaluate those types of workflows and think, are there ways we can make it a little bit more difficult to divert from those workflows without making it more difficult on the provider? You know, for example, a lot of those workflows require a username and password to be entered to complete them. Well, it's very easy to share a password, right? And like it or not, it happens all the time, right? So maybe there's a different way. What if we required a fingerprint biometric that's just as easy, but certainly requires the witness in that case to actually physically be there? So I would look through those workflows as well.
Excellent discussion. I'm thinking as our audience is out there thinking about, okay, I've heard this great information on EPCS. We've talked about inpatient, outpatient, handling of drugs, essentially. What should some key next steps and evolution as they kind of go back and make their to-do items from today's conversation? What do we see as key processes or key methods for them to chat about? I know that we gave them a lot within, but kind of let's think about kind of some wrap up next steps. Jason, Dan, if we want to kind of leave them with some best practices to consider.
Sure.
How about Dan, you want to hit the ambulatory side?
Sure. So a couple of things, right? So, and I touched on a few of these, but just to reiterate, one is certainly pay attention to regulatory developments across the board. More and more state laws around EPCS, PDMPs, and really other initiatives are being enacted, and you want to stay ahead of those so that you can implement it the right way and not be scrambling. You know, for example, the DEA is in the process of finalizing its interim final rule, which governs EPCS, and it'll become a final rule. They completed a comment process last year seeking input on all facets of the rule to make EPCS as efficient as possible. So we may see some changes to the requirements. We're unsure when exactly that rule will be released, but again, it may include some modifications that may require action. So we'll want to stay ahead of those. You know, just one related example is that recently the DEA released guidelines for transferring an EPCS order to a different pharmacy. So previously this was not allowed. And if you think about what that meant, it meant a prescription would be sent electronically to a pharmacy. Patient would get there, oh, we don't have that medication in stock. Patient would have to go back to the provider, get the prescription written again and sent to a different pharmacy that did. Now, very rightly, that the DEA now allows the one-time transfer of prescription to a different pharmacy. So the point is that they're really looking at this in real time and continuing to evolve the process. So it's definitely something we want to pay attention to. The other aspect is, from a regulatory perspective, is very specifically, I mentioned earlier, the Support Act, which requires EPCS for Medicare Part D. So all controlled substances prescribed through Medicare Part D must be sent electronically. And this year, 2023, is the first year that the CMS will enforce it. And in this measurement year, 2023, at least 70% of drug claims for controlled substances under Medicare Part D must be electronically prescribed after any exceptions are applied. So there are a few exceptions, technology failure, some other things. But once those are stripped away, 70% of all drug claims. So again, you really want to drive that adoption up because that's going to affect things like reimbursement. Now, penalties for noncompliance will be issued, and they're still in the process of figuring those out, and they will sort of get more severe over time or with more infractions. So again, I've said it a couple of times now, but I'll just sort of end with, you know, reevaluate that EPCS process from both a compliance and workflow perspective so that you're not behind and you can make sure you meet that Part D threshold.
And then I'll take a stab at it from the inpatient side. I'd say it's highly dependent upon where you are currently in your process of this. If you don't have a drug diversion management committee or process in place, start there. Develop a committee, multidisciplinary committee, read the ASHP guidelines, and start to implement some of these best practices that it recommends. But the number one is to have it recognized and under being used. And then the other one is a lot of you might be further along in your maturity and using software to monitor for this. And I think my biggest warning is that machine learning and AI will only ever be as good as the data as you provide it. So finding ways to validate and ensure that your data you're providing it is accurate and translatable is going to be super important. The standards, as we've all seen for stuff like laboratory, has started to evolve. We finally got HL7, and we have ways that we make sure that this data means the same thing in multiple systems. I'd say we're a little bit behind in the pharmacy world. Your Omnicell drug name is likely not going to be the same as your Cerner drug name. And so trying to match those up and cross-match them leads to harder to interpret data for those machine learning and AI. And if it doesn't know what the data means, it's going to have a hard time accurately catching diversion. So spend a little bit of extra time ironing out your data so that you'll be able to have a better detection program.
Thank you, Dan. Thank you, Jason. Really appreciated the discussion today as we took some time to share some best practices, really talked in great detail about drug diversion, EPCS, lots of great suggestions and information to share with our audience. I'll just close with a couple of items, which is if there's anything that we didn't capture or some questions that this led and follow up, let me know. We're going to share my email address in chat, so you're welcome to email me directly. Happy to get you any supporting information that we raised during the call today. Happy to share. I know we talked about fines and kind of how to get the attention of leaders, and let me know if we can get you some specific information to help out with internal adoption. Be happy to. We'll also wanted to let everybody know that we do these on a monthly basis. So please look forward to next month's knowledge sharing session. We're going to be meeting with Improvada's Compliance and Privacy Officer, Maria Phillips. We're going to spend some more time with privacy, kind of turning the corner from talking about drug diversion. Let's chat more about privacy. So for those of you that want to spend some time with privacy, compliance, I'm sure data is going to be of conversation as well. We're going to be tuning in again for same time next month. Well, not exact same time, but we'll send out some details for all. So to Jason, thank you very much for your time and expertise on today's call. Dan as well, thank you so much for your time and expertise on the call. And Allie, as always, thanks for keeping us straight on the polling and keeping us all in alignment. To all of you out there, have a wonderful day. And thank you again. We enjoyed our time with you.
Take care.